I see some people asking in the chat when we'll start. We'll start in just a couple of seconds. We're letting everyone in. Takes a couple minutes to do that.
Hello, guys.
Hi.
Hello. All right, we'll go ahead and get started, and we'll as people roll in. Feel free to welcome them in the chat as well. Hi, I hope everyone is doing well. My name is Ahmad. I am one of the executive directors here at M.D.s Empowered, and today I'm going to be facilitating this session. Before we begin, I wanted to let you all know that today we are going to be doing our workshop first, and then in about 50 minutes, our guest speaker will show up. They had to come, we had them scheduled a little later today, but no worries. We're gonna make sure we get the full program in today before they begin. For that, I will, again, I'm gonna, share my screen, and then we'll get to some reminders before we begin. Okay. Okay. 1 second. One second while I figure this out.
Also, just a quick reminder, I'm seeing some people join Zoom with like just their first name or their or just a name that isn't like their full name. So please make sure you change that now so that we can get you down for attendance.
Not this interesting. All right, I'm going to share this link after today's session in just so you can bear with me while I try and figure this out. Okay, welcome everyone to the Future M.D.s in STEM's a second international session for a 4th summer program. So we wanted to introduce everyone to one of our translators here, Yomna. She's going to be our Arabic translator here. And Yomna, why don't you introduce yourself?
Yes, hello. السلام عليكم. أنا اسمي يمنى وأنا اللي هساعدكم في الترجمة العربي بما إن في مصريين كتير قوي هنا. أنا المسؤولة عن الترجمة. Okay, so you wanted me to say the reminders in Arabic now?
Yeah, we wanted to just overview some reminders in Arabic, just in case we wanted to ensure that we are communicating all our reminders really clearly to all our participants. And we know we have a large participants who for native language is Arabic, so we wanted to provide the instructions to you in Arabic as well. So yeah, Yumna, feel free to do that. We would love.
Okay.
Yes.
Okay, so first نحب أقول لكم بس يا ريت تسمعوا الجستس بتوعنا، عشان احنا بنستضيف دكاترة، فيا ريت يعني تحترمهم شوية. يا ريت محدش يفتح المايك، يعني طول ما في حد بيتكلم يا ريت محدش يفتح المايك. وبالنسبة للأسئلة فهي إن شاء الله ليها وقت في الآخر. تمام. اللي عنده أسئلة كمان ممكن يبعت لي بعد ما السيشن تخلص، ده لو ما لحقناش نجاوب عليها. بس بشكل عام يعني في آخر نص ساعة هيبقى الوقت المفتوح عشان يسمعوكم ويجاوبوا على أسئلتكم. بالنسبة للشات يا ريت محدش يكتب رسائل ملهاش لازمة، لأن للأسف ممكن يطلع برا الكورس. ويا ريت بالنسبة بجد للميوت، يا ريت يعني أي حد عنده سؤال يرفع إيده. وبالنسبة للشباب اللي بيشتكوا إن هما بيتكلموا بسرعة، إن الإنجليزي بسرعة، في حاجة اسمها كابشنز. لو أنت فاتح دلوقتي الزوم هتلاقي في الإعدادات تحت شات ورياكشنز وشير وكابشنز، يا ريت تفعلها. Okay, I think I finished now.
Okay, thank you so much, Jomna. We really appreciate it. So yeah, we just wanted to communicate all our guidelines and reminders, just so everyone can clearly understand our expectations of everyone. And again, we are expanding our translations team. So if you do want translation services provided in another language that's not English or Arabic, feel free to message Davina and we will try our best to accommodate for you. All righty. So you will begin. Okay. So on the sheep scale today, how does everyone feel? How does everyone feel?
4.
4.
2.
4.
I
9.
7.
5.
4.
7.
9. 5.
4.
3.
okay. Let's keep it. Let's answer in the chat.
3.
2. 4.
It's great to
شباب
see
لو
you.
سمحت ممكن نقفل المايك، ويا ريت تكتبوا في الشات.
Oh, can you hear me? Okay. Okay, sounds good. I think okay, sounds good. I feel everyone has a very wide, different range of emotions today, which is totally okay. I think I'm feeling more of like maybe like a 4 or 5 right now. It's really early where I am, but it's good. So yeah, let's get started. So today our primary objective is to go through common medical tests, vitals, procedures, and responses. We're going to dive into phlebotomy. We're going to talk about IVs. We're going to talk about what vital signs are, how they're measured, why they're really important. We're going to talk about we're going to talk about what a code blue means, what the response is. And we're going to ensure that again, please ensure that during presentations that if you can keep your mic off and keep all questions and comments to the chat. That will help us ensure that we have a smooth presentation. I will definitely try to keep a very steady pace as I converse with this workshop, just so it's easy for you to understand. And I will try my best to not rush myself or talk fast, because I know a lot of participants are wanting me to talk slower and ensure they understand. So I'll try my best to do that. If I do go ahead of speed, please let me know. Thank you. Okay, so before we start, let's talk about vitals. What are vitals? What are common vitals? And yeah, so the common vital signs that are usually measured when you go to the doctor are, or you go to emergency room or another medical setting, and if they want to like see your current state before they develop your differential diagnosis, they're going to take some vitals. The vitals usually include your body temperature, a pulse rate, a respiration rate, and a blood pressure. Does someone want to either unmute or type in the chat why they think vitals are important? I'll check the chat. Why do we think vitals are important in the understanding of, yeah, Kenzie?
Hi.
Yeah, hi.
Yeah, I think they're important because each one basically like represents an important organ in the body. Like The respiration rate represents the lungs. So if there's an issue with the pulse rate, for example, then the heart has a problem. So they're just indicators to the whole health report.
Amazing. I love how you refer to them as indicators because they're essential indicators or for your overall health in your current state. I see the chat, people say signs of life, correct. They tell us if the body is working or not, correct. To know if there's an issue, correct. It's a good reference point. It helps diagnose. All are correct reasons why vital signs are really important. So again, I think you guys covered most of these already, but vital signs are really important because they're really, really easy to measure and they provide such a comprehensive view of what's going on and the problems that could potentially be arising in your body. Again, they usually take about 30 to 40 seconds to measure, and sometimes it's even faster. Nowadays, technology has advanced how vital signs are measured, and usually there's like one machine that does it all. And usually when patients have this machine, it just tells the doctor or the nurse that's caring for the patient vital signs immediately. So they don't even have to do the traditional methods of, checking the vital signs. So it's really cool how technology has kind of advanced this, how vital signs are measured. But again, some of the main points are that vital signs help detect problems. Again, they're really easily measurable, and they're relatively really quick to measure. So what is body temperature? Here's one of our first, vital signs. So body temperature is what the normal range, how your body is measuring. The normal temperature for individuals is kind of, how you are measuring. So usually normal body temperature can range from 97.8 degrees Fahrenheit to 99 degrees Fahrenheit. And the normal temperature can range differently for individuals based on activity levels, gender. These all kind of contribute to your body temperature as well as your current state. So if you're really sick, your body temperature will be higher. If you're healthy, your body temperature will be normal. And there are certain ranges which are normal and certain ranges where you could declare a medical emergency. And we'll talk about what this is in a second. Does y'all want to type in the chat some common ways that we measure body temperature?
By thermometer.
By thermometer, correct. And again, thermometers really good. You can place a probe under the mouth, the rectum, armpit, correct, perfect. This is perfect, exactly. So you can take your body temperature in multiple ways. One way you can take your body temperature is rectally. And this is usually has a kind of uncertainty of 0.5 or 0.7 compared to the mouth. So it's not the most accurate, but it is one way that in a clinical setting, if no other options are available, rectally is a way that a body temperature is measured. Again, one of the most common methods of getting your body temperature measured is orally. And this is going to be through either a glass thermometer or really nowadays, as again, technology is advanced, we have digital thermometers that you place under the tongue with an electrical probe, and that is easily used to measure body temperature. Check in the chat. Perfect. So axillary under your arm is also another place where your temperature can be taken. Again, it does have an uncertainty and it can be either 0.3 or 0.4 higher or lower. So again, it's not really the preferred method, but it is one way if needed to measure your body temperature. And by ear. Ear is also one of the most effective ways to measure your body temperature, and it's easily, you kind of put it in the eardrum. Again, your eardrum kind of reflects your body's core temperature. So it's a really effective way of knowing the most accurate way of knowing your body temperature. So we discussed a couple of ways. Again, body temperature is really easily accessible. As you can see, it's not difficult to measure your body temperature. And another way that you could measure your body temperature is by skin. Again, during COVID, this was kind of very cool. I didn't ever see these machines before. People, it's called doctors, physicians, and nurses. They would use kind of like a little a really special thermometer and they just kind of scan it above your forehead and it tells you the body temperature. It's kind of used some really unique sensors to determine your internal temperature. So again, it also is a really, really accurate way. And I think this type of thermometer is becoming kind of standard of practice nowadays, just because it's really, it's hygienic, it's clean, and it's kind of fast and convenient. Yeah, so a question I want to ask the chat: what is the most effective way to measure body temperature? Okay, you're correct. Perfect. That is one of the it's really good. Ear by skin, correct. Perfect. Exactly. We'll keep this question for the comments. I'll take questions towards the end of the workshop. Yeah, by ear, by skin. Again, some of the ways that aren't usually preferred is, for instance, rectally. That is one that is, or axillary, or under your arm. Those can kind of be uncertain sometimes. Let me just quickly put my laptop. Sounds good. Okay. Okay, so body temperature. So if your body temperature is abnormal, so if the doctor or the clinician takes your body temperature and it's abnormal, you can refer to these as two common ways. So hyperthermia. Hypothermia is when you are below the optimal range of where your body temperature should be, around 95 degrees. It's below 95 degrees Fahrenheit. And if it's above 98.6 is when you have a fever. And in between that is kind of the sweet zone of where you want to be. I think 97.8 is what you should aim for as your optimal ideal body temperature. Okay, another common vital sign. So we've talked about body temperature, and we also talked about, now we're going to talk about pulse rate, which is another vital sign. So the pulse rate pretty much measures your heart rate and the number of times your heart beats per minute. And this is essential to know, and it is essential to know your pulse rate, because it indicates your rhythm of your heart and your strength of your heart. And it's measured by like looking into your how the heart pushes blood through the arteries and how they expand and contract and how it contributes to the rate. There are ways to measure it, and we'll talk about it now. So the normal pulse rate for a healthy adult ranges from about 60 to 100 beats per minute. Again, with exercise, illness, injury, emotion, stress, it can all kind of fluctuate. But 60 to 100 beats per minute is what is like optimal and ideal. And there's ways that we can measure pulse rate too. And you don't really need a specific thermometer or a machine to measure your pulse. You can actually do it right now during our session if you really wanted to. So I wanted to ask, what are the three major arteries that we could use to measure our pulse rate right now? Does anyone know? Our hand. Do you know what it's called specifically? Okay, brachial radial, the radial artery. Perfect. Really nice. Okay, carotid artery. Exactly. Perfect. Those are some of the yes, so those are some of the key places where we can measure our pulse. So again, carotid, brachial, and radial. These are some of the three major arteries that we can use to measure our pulse rate. And again, you can, to measure it right now, for instance, you can have a picture. So if you wanted to measure your pulse through your carotid artery, you can actually put your about 2 fingers on your carotid artery, and you can kind of feel it. And also you can do it similarly for your radial artery, which is kind of below the thumb. One of the key things that you should not do whenever you should not do this if you are measuring your pulse, is using your thumb to measure your pulse, because your thumb has a pulse of its own. So you do not want to have it interfere with your pulse measurement. So you'd want to use either your 2 fingers, and yeah, if you want to take a second and kind of feel around your thumb, I think this is the easiest one to find for me. But if you feel it and you gently just kind of hover your fingers over your under your thumb near your radial artery, you can kind of feel it. You can kind of feel it. Is anyone able to find their radial artery in the chat? Let me know. I'd love to see if You guys are able to find it. Cool. Nice, nice. Okay, if you need help, of course, let us know and we can help you find it, hopefully. You definitely have a radial artery. If you are alive, it should definitely be working. Okay, so we talked about temperature, we talked about your pulse, and now we'll talk about your respiratory rate. And a respiratory rate is a number of breaths a person takes per minute. And this simply is involved by counting the number of breaths in 1 minute of counting and how many times, and just viewing how many times your chest rises. And usually for adults, the normal respiratory rate is about 12 to 16 breaths per minute. And again, respiratory rates can increase by fever, illness, and other medical conditions. It all factors into your respiratory rate. This also is a really, really important what's it called? Vital to know. And as I'm talking about these vitals, they all play a role in like emergency response. Like we'll talk about it really soon, but like for instance, in like an emergency situation, such as a code blue, you'll want to know what the vitals are immediately, just to know how the patient is doing and how you can best assist and what medications to administer. So what is blood pressure? This is also a really important what's it called? A vital sign. So the blood pressure, it's the force of blood pushing against the arterial walls during the contraction and the relaxation of the heart. It's a really important vital sign. And each time your heart beats, it pumps into the arteries, resulting in a high blood pressure, which is your diastole, and your syastole, which is when your blood pressure falls and your heart relaxes. And this is commonly known as like the systolic, diastolic, and there are normal ranges for that as well. Systole, I believe. I'm sorry if I pronounced that incorrectly. Okay. Again, normal blood pressure, which is what you want to aim for, is when your systolic is about 120 and your diastolic is less than 80. So 120/80. If you've heard these measurements, this is kind of known as your normal blood pressure. And if your blood pressure is elevated, so if it's from if it gets elevated, it can what's it called? Suggest that something is not right, and high blood pressure can it's a vital sign that doctors can know to determine a diagnosis if you have high blood pressure. Again, 120 to 1, there are different stages as well. So if you are elevated blood pressure is whenever you have your systolic ranges from 120 to 129, and your diastolic is less than 80. And stage 1 is whenever your high blood pressure is whenever you have your blood pressure even higher. So it's 130 to 139. The next stage is 140 and above as well. All right. So that is kind of blood pressure measurements. What are the medical terms used to describe whenever someone has a low blood pressure? Think about your medical roots, and let's put it in the chat as well.
We have some hands raised that want to like answer. Are we?
Yeah.
Okay.
Of course. Just let's call on them. Yes, Sarah? Sorry.
I think when it's low, it's hypotension, and when it's high, it's hypertension.
Perfect. Hyper and hypotension. Now, which one specifically is for low blood pressure? Hyper. Okay, exactly. Hypo is when it's above the normal range, and hyper is when it's below. Perfect. Y'all already, I'm so proud of y'all. Y'all are getting this down. Perfect. Again, blood pressure is also, again, nowadays, like usually there's a what's it called? Traditionally, how blood pressure is measured is by using like what's it called? It's a whole like process of measuring it. But nowadays it's so easy to just use like a machine to measure it using a cuff. Does anyone know what this is called? Yes, we will make sure that we are yes. Hypo is low and I'm sorry. Exactly. I think hypo is low and hyper is high. I'm sorry. I just flipped that on accident. Exactly. Sorry about that. Yes, hypotension. Great job for catching me on that. Exactly. Hypo is when it's low. Hypertension is when it's high. Okay. Does anyone know how to pronounce this? When you measure blood pressure, this like cuff, what it's called? I know some people put it in the chat. It's called a sphygmomanometer. I think this is the first time I pronounced it right. I'm so proud of myself. Sphygmomanometer. Sphygmomanometer is what is used to measure your blood pressure. This is the cuff that's used. Perfect. Exactly. Great. Okay, so now the next step. So your vital signs are determined. Now, doctors, physicians, and most of the time, what happens, the next step is to determine what's going on. For instance, if your vital signs are low and they want to determine your red blood cell count or your hemoglobin, that's all going to be measured through a blood test. And again, the blood test is the most accurate way of knowing what's going on in the body. Exactly. Perfect. Okay. Great job, everyone. It gives you the complete blood picture. Exactly. So again, you're a patient. A patient goes into the ER, correct, and they feel sick. Doctor's going to complete a differential diagnosis. Again, this involves constructing a list of possible conditions and patient symptoms. And afterwards, the doctor is going to order some blood tests to either confirm or decline what they believe is going on. Again, your blood tells everything. Without the blood test, there is no the doctor won't know what's going on. It's really essential that the blood work is done. And yeah, that is part of how it works. Again, blood tests tell a lot about what's going on in a patient. Okay, so to talk about blood tests, let's talk about what blood tests are, who does the blood tests, and how it works. A lot of times when you go to the doctor or the hospital and you get your blood test drawn, you have like a wide range of colors. I know when I first didn't know what they meant, I was like, why is there like 10 different tubes? They all look the same, but they all just different colors. This is the different colors are correlated with the different tests that can be run within the tube. And we'll talk about the specific tests that each of these tubes can run. But before that, I wanted to talk about, again, the person that draws the blood in the hospital is known as the phlebotomist. The nurse and the physician sometimes helps out, but usually a phlebotomist is the person that, again, draws the blood. And like I said, each tube color indicates the test that can be performed and what department the test is for. And one thing I wanted to emphasize is order of draw. So whenever you go to the doctor, you might think, you might see all the different colors, but all the different colors are really, it's a very organized way of collection. So they can't just draw the lavender tube before the red tube, before the gray tube, before the blue tube, before the pink tube. Everything is situated in a protocol. So your blue tube is always drawn before your red tube. Your gold tube is always drawn before your light green tube. And again, just like that, it's an order. That's what's called the order of draw. And the importance of this is to ensure that there is to prevent cross-contamination between the tubes and the additives. Each of these tubes, again, go to different departments, but they also are built differently internally. If you look at these tubes, I actually have some to show you. This is a green top, which has an additive called lithium heparin. As you can see, how this looks is very different than how this looks. This doesn't have this serum layer. This does have the serum layer, and this does not have the serum layer. Again, this is because the additives either accelerate or inhibit the clotting of blood. Each tube has different clot behavior. So sometimes some tests you want the blood to clot, and sometimes you don't want it to clot. So it just depends on the test that you are running. And that's why every tube is different. They have different additives for every tube that you draw. The gold tube is usually its additive is called, it's a serum separator tube. So it is really generic. But these ones, the green and the purple one, they have specific additives. This one has EDTA. And this one has lithium heparin. And again, you can see the lithium heparin on the bottom of this, in the serum. And then in this tube specifically, this has potassium or EDTA in its, what's it called? On the lining of the tube. If you look very closely, I don't know if you can see it perfectly, but there's just like kind of like a foggy mist that surrounds the tube. And this is the EDTA. So I actually am a phlebotomist. I do work in a hospital and I do perform venipuncture. So I decided to show you how it's performed because I think it's extremely important to know how to do this if you're going into the medical professional. So as a phlebotomist, the first thing that you usually do, I'll skip some steps here, but first thing you want to do is you want to find the vein that you're going to use. And it's easier said than done. Everyone has a different kind of pattern of veins. While, you know, usually it's like the M pattern or the H pattern that's kind of like used as like generic. It's not, it's kind of in clinical practices, it can be really difficult to kind of like follow that pattern. So what it kind of entails you to do is rely on your hands and your fingers completely. So yeah, what's it called? To find a vein, you can't really like memorize how a vein will look like or memorize, hey, the cephalic vein or the median cuboidal vein will always be right in the middle. Yes, it's supposed to anatomically be in the middle always, but sometimes a patient is dehydrated or their what's it called vein isn't easily accessible. So you're not going to be able to find the vein really easily. And it's just going to be your fingers. You're just going to rely on your fingers to find the vein. And there's some techniques that we use to, what's it called, help accelerate this process because it can take a very long time sometimes. I think the longest patient that I have been in, okay, there is a type of light. I see a question. There is a type of light, but the light does not work really well. Again, it is not as accurate as your fingers because the light, it's very like, it doesn't show you depth of the vein. So it just shows you kind of like a whole, it's kind of like an ultrasound machine. It kind of gives you the whole picture, but it doesn't show you how deep it is, what angle it's at. And the best way to know that is to use your fingers. Again, I do not, what's it called? I never kind of used a light to use to find the veins. I have learned to rely on my fingers heavily because again, if you're in an emergency, you don't always have the time to go and get the whole machine out and put all the, what's it called, necessary equipment to perform like an ultrasound type machine to find the veins. So what you need to do is we use a tourniquet and we put it really tight. Once the tourniquet is on, it usually kind of push up the veins, and then using your fingers, you can actually feel to find the veins. If you make a fist right now and you just kind of briefly scale across your this is called the antecuboidal fossa. This is the region where you mostly get your blood drawn. I don't know if you can see, but you can just kind of what's it called, put your fingers across this area, and then usually if you are hydrated and you have and it's like palpable, you can feel the vein. You can feel the vein. I'll give everyone a couple of seconds to try and find their vein. It's not easy. Again, I don't think like when I first went into this field, I thought it was going to be really simple. Like I would be able to find a vein like this because I memorized every single possible anatomical way a vein could present itself. But it's not that easy. You're going to have to play around and palpate a lot to find a vein. It feels very bouncy. You should feel for a bounce. Like I feel one right here. Like you can't, when I first started, I was like rubbing that area. Like I was trying to like so hard to like find the vein. You have to be very, very gentle. And you just want to briefly like, what's it called, graze your fingers and palpate really smoothly. And if you are, you can feel the vein. Again, usually it takes a couple minutes and usually you will need a tourniquet. So if you don't have good veins, you might need a tourniquet for it to like palpate up. But that is one way of kind of finding a vein. And what's it called? That is how you find a vein. We'll go into blood collection in just a second. Another place where you can find a vein is in your hand. Your hand has really good veins as well. And sometimes even if you just look at your hand, you can see like a dark green marking, which can help you kind of situate where your vein could possibly be if you put a tourniquet on. And if you have good hand veins, just feel free to palpate. If you palpate, you can feel the vein. You'll know how, like I usually tell when people are first starting out to find veins, it's usually easier to find them in the hands just because they're usually really present. So if you feel it, you can learn how it feels like so that you can apply similar strategy on your AC area or your antecubital area. So again, you found a vein, sometimes you'll find it in this area, sometimes you'll find it in the hands, and other times you won't find it in the hands or the AC area, and you're gonna have to go to the arm. And then again, you can put a tourniquet on, and there's some places where you can find veins in the arm. We won't get into that today, but there's a lot of ways there's a lot of veins in your arms. And I've drawn people from up here towards the elbow, all the way from the upper arm, lower arm, hands to the fingers. So there's a lot of ways you can draw people. And again, if you do go into the field, you're gonna learn that it's like every patient is different. Not everyone's gonna have the same vein structure, the vein type, and that what you do for one patient is gonna completely differ from what you do from another patient. Okay. Yes, children, you do the similar exactly. They have the same structure as well. For where you can find the veins. You will use the AC area on the hand. Usually children are really, really easy to find their veins. Like it's pretty simple to find for children. Okay, now that you've just found a vein, you can pick your needle collection device. So you have, what's it called? 2 different ways you can draw blood that I suggest doing. Babies, a lot of times for babies, the nurses actually draw them. And that will be usually through the finger, from what I've heard. Again, there might be other ways of, I don't think they put like, what's it called? Full needles into like a straight needle into a baby. They use probably different collection devices, but I haven't drawn on a baby, so I wouldn't know that. But I can definitely look it up if you are interested and find an answer for you. But usually it's gonna be towards a finger poke, from what I've heard and learned. And you can also do it on the feet. Yes, very last option. If you can't find it anywhere, and you've consulted with a doctor and the physician, and 2 or 3 other phlebotomists have come and tried to draw the blood, then you can, if the doctor suggests that you can draw on the foot, you can draw on the foot. I've never drawn on the foot, so there's always ways of finding a vein on your arm. I don't think I've known anyone in my hospital that's drawn on a foot, unless it's someone who has a lot of IVs and tubings and edema. So again, another thing that happens when you work in a hospital is you're gonna have people that have 4 IVs on their AC area, another IV here. And when the IV is in the arm, you don't wanna draw from the IV because it can mess up the results of the lab draw. So then you have to find alternative ways to draw the blood. That could be to the finger, could be like in the wrist area. Again, a hospital is constantly, there's always constantly patients have various conditions. So but the hardest patient that I have seen is when a patient has edema, or when they have kind of like a fluid base, their hand is full of fluid. So then you have to push down under the fluid to find the veins. That is extremely difficult. And we'll talk about IVs in a second. We'll get to that. But yeah, that's kind of how, how it kind of works. Again, you're not gonna always find it in the AC because there might be an IV, this IV is kind of where it's kind of like an intravenous needle that nurses place to administer medications. Yeah, so you found the perfect vein that you're going to go for. You have 2 ways of measuring, 2 ways of kind of extracting the blood or performing the venipuncture. You can use a straight needle. The straight needle is kind of the most common way of drawing blood. So pretty much this is kind of how it looks like. This is a blood collection device. You'll open the needle. First, you'll make sure you use appropriate like alcohol swab to make sure it's very clean. You're gonna wear gloves. and then you're gonna open the needle. I open the needle, here's the needle. Then you're gonna go into the vein slightly. And usually you'll feel like a resistance. Like it's hard to explain how it feels like unless you do it. But once you've put the blood, once you've kind of once you've poked the vein, you will feel kind of like a resistance, and then you can use your tubes. Again, I have 2 tubes here. Based on what I talked about, which tube would I draw first? Again, we'll have polls coming soon. Green, exactly. Green is first and then purple. So you'll put the what's it called, the tube inside the this device, this blood collection device, and then usually blood will start coming out. Sometimes you might have to readjust a little, hold back. You might have to like what you don't want to do is fish. That means when you're in the vein, you're doing this. That hurts really bad. So don't do that. So you have to be really careful in how you do it inside the patient's arm, because if you do like fish a lot, or you poke really deeply, or you do it really not if you don't do it gently, it can cause a hematoma to form. That's when a blood clot forms in your arm, and it's kind of dangerous. So you don't want to do that. So yeah, you kind of hold the needle bevel down, bevel up. So if you look at the needle here, there's kind of like a curve. It's called a bevel. So this bevel is always up when you're drawing blood. So when the bevel, you put the needle into the patient, the bevel is up, and then you collect the blood. And then these are little like syringes that you can use to kind of like pull, like hold down to the tube. And then you can, what's it called? Yes, you can, what's it called? Change the tube that you, all the different tubes. So yeah, this is one. And again, once you finish with it, you want to immediately close the needle with this blood, what's it called, with the safety guard, and discard of the needle immediately. What you don't want to do is what I did a couple of weekends ago, is when you accidentally poke yourself with the needle that's used. If that happens, it's I think I've done like over like 2,000 sticks, and that's only happened to me once. You will have to get like tested for various diseases, and that is a whole nother process. So make sure you're really, really careful when you're drawing blood. What's it called? Another way you can draw blood, especially if a patient has a really, really small, very small veins, is using a butterfly needle. So butterfly needle is very simple. It's very simple to use, but it's a smaller needle, and you have much more control. So you use the wings on the needle to insert it into the vein. And what you do is you actually use a syringe to slowly draw up the blood. So the good thing about a butterfly needle is when you get into a vein, it will tell you if you get into a vein or not. So usually there'll be a flash, or a blood will kind of spew into this area. And what you'll do is once you see the blood in here, you can easily bring the blood up. Again, you want to bring it up very, very slowly. Because if you do bring it up, like what I've done in the past is I've just like bring it up really fast. And when you do that, it hemolyzes the specimen, or it destroys the red blood cells, and then it's not effective in testing anymore. So you want to make sure you don't do that. And yeah, this is another way that you can collect blood, is using a butterfly needle. So you have a straight needle stick and a butterfly needle stick. Again, if you want pictures, I can send these to you individually later if you want to look at it more closely, if the camera is not clear. Sounds good. Okay, like I was talking about, finding a vein is much more difficult than you think. This is a patient arm. Again, you can't easily see the vein. It all relies on your finger on finding the vein. And these are the common veins: the basilic vein, the median cuboidal vein, and the cephalic vein. The order which you should proceed to draw blood is try to find the medial cuboidal vein, and then keep the basilic vein for your very last option. This is the one that's the most closest to nerves. So you don't want to damage any nerves by accidentally poking a needle on a nerve. So make sure you don't try and avoid that area, and try and go for one in the middle, or a cephalic vein. Again, you can perform blood tests on your hand as well. You have tons of veins on your hands. But again, you need to be very, very gentle. You can only use this needle, which I know some people that use straight needles in the hand. I do not recommend it. Um, if you do not enter a vein, I see a really good question. You just try again. That's happened all the time for me. Like you go in, you think there's a vein, but it just collapses or you can't find it. Then you just find another vein. And it's really, really common to miss a vein a couple of times here and there. That is totally normal. I think I draw like 30 to 40 patients in the morning and I miss maybe 2 or 3 based on, again, what happens. Sometimes they flinch or they move their hand back, or the vein just collapses, or it's not a good vein, it's too deep, that I just kind of remove the needle. Okay, I think we already did this. You did find your vein. If you need help finding your vein, again, you just need to put a tourniquet on. I don't know if you don't have access to a tourniquet, then it's going to be hard, but you just want to kind of palpate. You just want to palpate, and you'll feel it eventually once you've learned kind of how it feels like. And once you're really hydrated and you just play around a bit, you will find your vein. I was so interested when I first started learning about phlebotomy. It's like, where is my veins? And my veins were difficult to find, but eventually when you kind of make a fist, they pop up. That is easy to do. Okay, so most routine lab draws. When I go on my morning runs, again, the green and purple tubes are the most common ones that I use. The green tube is used for pretty much all your routine chemistry tests. And your lavender top, your purple top, is used for most of your hematology tests. And hematology is referred to the study of the blood and the blood-forming tissues. So in this green top, you can perform a BMP. So your doctor might ask, hey, I want a BMP and a CBC. BMP is a basic metabolic process. This kind of tells all the basic, like, what's called specific biomarkers in your blood, such as your blood urea, your creatinine, your kidney function, sodium, potassium, chloride, all very essential, what's called values to know for a doctor. Again, it helps with what medications they want to give, what concentrations of the medication they want to give. And then you have your lavender tube, which is used for hematology studies. And this can be used primarily for your CBC. And this tests for infection in your blood, your red blood cell count, a white blood cell count, tests for leukemia, infection in the blood. Everything is determined for those tests in this tube. You can also do your hemoglobin and hematocrit, which again is your red blood cell measures, and this can help identify various blood-related disorders. So yes, you have to be very specific. So you can't perform a BMP in this tube. You can't perform a CBC in this tube. So whenever your doctor asks, like I'll have a doctor or a physician come up to me and like, hey, can you perform a sodium test on this patient? Then I have to think, okay, what test does a sodium consist within? And that's going to be your basic metabolic process. Then I'll draw this tube. And sometimes they might ask for a complete metabolic process. That is also in this tube as well. And this is kind of just additional tests on top of the BMP. They didn't include it here because they're really, really, really specific tests that your doctor might ask for. Cortisol is one that also is an additional test that it can be measured. And that's how your blood responds to different glucose measurements. Then you also have some other tubes that are really commonly used for other special chemistry tests, such as the gray top. You have your coagulation studies, which how fast the blood clots. This is within the blue tube. And then for seeing, again, we talked about why it's important to be filled in a specific order. It's because each tube has a different additive. And if you mix the additives, it's a specific term. It destroys the sample. In simpler terms, it destroys the sample because then you're mixing the different additives. Because when you place a tube, do you see this needle? If you see this, like inside this Vacutainer hub, there's a small little needle that you push in to make the blood blood enter the tube. So whenever you inaccurately when you inaccurately put the wrong tube in the wrong order, you're exposing the specimen to the wrong additives. So you don't want to expose, for instance, EDTA before you expose lithium heparin. So it's just really specific. And the specific details, again, I'm not really kind of sure of, but that's kind of like the whole picture. And this is all the people that test your blood are known as the medical laboratory scientists. And I know they tell me, never put the green before the purple, or never put like the gold before the gray. So it's just how it works. It's kind of just how it. Are needles used to blood? Yes, needles. Okay, what I do is completely extracting blood from the patient. I'm never introducing something into the patient. So I'm never administering a medication. I'm only taking the blood out. So venipuncture and phlebotomy is used for removing blood from a patient. And whenever you administer an IV is when you use a needle as well, but you're administering drugs into the patient. So you're not taking anything out, but you're actually administering blood. Just for the sake of time, if you have questions about my specific journey of how I got my phlebotomy job, again, it's honestly, I don't, we have international students here. I can provide the best tips that I can. But I was, again, rejected like to 8 to 20 positions before I was accepted to the one position that I was accepted for at my current hospital. This shows you how difficult it is to kind of find a job in healthcare, especially where I live. So I can explain to you all the process. If you need help, application tips, how I got my license, I can help you out with that. Just message me on Slack. Again, yeah, let me know and I'll answer some questions. Again, we'll send a poll out in a bit for attendance. So don't worry about that. If you're here right now, we will definitely get your attendance. And yeah, IV, again, an IV is kind of opposite of venipuncture. An IV is when you insert like a needle and you administer drugs inside the patient. So if you see, it's kind of similar and kind of different. I won't go into specific steps of that today, but you put blood, you insert the needle and then when you take the needle out, it actually inserts a catheter. So the needle is protected within a catheter and then you can administer any drugs or fluids into the patient. That's kind of the main way of what's called delivering fluids, medications, and other substances into a patient's bloodstream. An IV, again, is very similar. You got to know how to draw. You got to know how to find the vein. You have to follow the same kind of standards and guidelines. It's really important that you do so. And IVs are, what's it called? Whenever, for instance, if a trauma comes into the hospital, you have to be able to do this really quickly to administer the right medication. And it's really important. So phlebotomists don't administer IVs. It's usually the nurses that do that because it's a really, because we can't administer medication. So there's no reason for us to administer an IV. I have helped a nurse find an IV, find a vein for an IV before, but I've never helped insert one, not yet. Okay, so before we end this session, I'll kind of overview what a code blue is. So in the hospital, there's different codes that can be called, and a code blue is used for a medical emergency, and it indicates cardiac arrest or a medical emergency that requires immediate resuscitation. Usually, it's really, really organized. A phlebotomist usually responds to code blues. Usually, we are asked to draw blood on the patient whenever they are in their code, just so the doctor can know the values that they need to know. So sometimes they'll ask, hey, draw a basic metabolic panel. So I'll come in with my needle and I'll get a green top and I'll run it down to the lab right away. Again, the goal of a code blue is to provide life-saving interventions like CPR. And it's really, really cool to see how a code blue is like, how everything is structured. Because there's like, honestly, like 20 people in a room. There's a respiratory tech, there's a phlebotomist, there's a house supervisor. The coordination is really, 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 really cool. Again, everyone has their role in helping make sure the patient gets stable. Again, usually before a code blue is called, a rapid response is usually initiated. So for instance, like the vitals we talked about earlier, if your respiratory rate drops dramatically, or your heart rate drops dramatically, or you lose a pulse, a code blue is the nurse or whoever finds the patient in the state will, again, call a code blue. And usually they'll know if a patient is going to code because they have a score called a M.D.s score or the modified early warning score. So the doctor or the nurse knows to be like cautious of this patient because they have a concerning respiratory rate or heart rate. So before a code blue is initiated, sometimes they'll call a rapid response. And this is to tell everyone in the hospital, we might experience a code blue any second. So be ready. And a code blue is called whenever the patient goes into cardiopulmonary arrest. Okay, again, blue score. We talked about this a second ago. Blood pressure. If the blood pressure is in a specific range, if it's hypertension or hypotension, if it's not in the normal range, if it's too high, it's elevated or it's low, it all contributes to the mu score. Again, we didn't talk about the specific medical term for whenever you are breathing really fast, but that's called tachypnea, and bradypnea is whenever you're slow, when you're breathing really slow. And it's really cool to hear when a code blue is activated, how the doctor or the physician or the nurse will be saying how they kind of describe the patient. The big patient has been tachypneic for, or the patient is has been what's it called? The patient has a low respiratory or a high respiratory rate. They'll say specific medical terms associated with what's going on. And it's really cool to see how they kind of situate the patient to ensure the doctor knows exactly what's going on. Again, temperature, again, I wanted to show you kind of like what normal temperature is, 98.6, and then what calls for a medical emergency. Again, pulse, if the patient loses the pulse, the doctor has to know that, or if the pulse is too low. And oxygen saturation is also another vital sign that we didn't talk about today, but is one that is really important. So normal oxygen saturation is between 95 to 100%. And oxygen saturation pretty much refers to the measurement of the oxygen saturated hemoglobin in the blood. And it kind of is really important to indicate, it's an important indicator of the oxygen carrying capacity of the blood. And if it's too low or too high, again, there's specific terms that go with that. Hypoxia and hyperoxia is those terms for that. Check for any questions. Again, mu score is really important in determining if a patient is either going to code soon, and sometimes a code happens just naturally, like it just happens. And then you have to, no rapid response is called, and then everyone kind of has their place to respond to the code. Now that we talked about most of our like vital signs today, here is kind of what most of the time, a vital signs, the doctor, the nurse isn't kind of measuring the vital. Sometimes, of course, the nurse will measure the vital signs, but most of the time, the machine is there. The technology is doing it for you. So this patient, their O2 saturation, do they have normal O2 or low O2 right now? Their oxygen saturation. Again, usually when you go to the doctor, your O2 saturation can be measured using a pulse oximeter. This is a little thing they put on your finger. And this kind of is a device that measures it through light wavelengths, but there are other ways to measure it as well. And usually when you're in the hospital, you'll see people already have it kind of on their finger already, so that it kind of loads onto the screen. You have your ECG strip you also see, and again, low, exactly, they have low. And their heart rate, what about their heart rate? Good. Okay. Great work, everyone. So yeah, now that you understand some of the vital signs, apply it to this image. I know, again, respiratory rate, we talked about O2 saturation, we talked about blood pressure. Is this patient's blood pressure high? And what's a term for that? Exactly. Perfect. Blood pressure high, stage 2. Again, just knowing the vital signs tells you so much. And it kind of is really important to know. That's why we wanted to spend some time explaining each of them to you. It takes a lot of practice. So you have to be a very visual person, because this can change like this. Your vital signs can change like this. And you have to know, you don't have your notes by you to know, okay, what's going on here? Or, hey, the blood pressure, what's the normal range? You kind of have to know immediately, and maybe why it's causing that. Again, a code blue, this is kind of steps for a code blue, the different stages, different responses, and different assessments. Again, we'll send these slides out to you, so you have what's it called, you can view the specific steps. And then when a code is initiated, again, it's the main goal is to provide those life-saving intervention, initiate CPR, defibrillation, if there is a shockable rhythm identified. If there's not a shockable rhythm identified, then AED will not be, or defibrillation will not be effective. And some of the common medications are epinephrine and amiodarone are two common medications used in a code. And I'll tell you about their specific roles in a second. Again, during the code, it's really important that communication is key, but amongst the nurses, the respiratory techs, the lab assistants, the phlebotomists, everyone has to be really, really communicative. Again, and you always have, most of the time you have a crash cart with all this medication already there. So you don't even have to like the nurse or the physician in the lead doesn't have to they don't have to, what's it called? They don't have to go and find the medications. Okay, again, different codes. Again, usually when a code is initiated, if the patient isn't already in the IMC or the ICU, they will be transported there. And again, epinephrine and amiodarone are the two common medications used in the code blue. There are other medications, but epinephrine, it kind of increases the cardiac output and what's it called? Constricts your blood vessels and allows your airway to relax. And amiodarone is used again for ventricular arrhythmias, sign of electrical issues with the electrical signals of the heart. We learned a lot today. I know our guest speaker is here. Alex, welcome. Thank you for being here. We just finished our workshop, and everyone, we're going to send this workshop out to you all. So do not worry. We have a couple more information here as well. And I'll also send out some practice questions and examples for you all to look at as well. Again, feel free to message me on Slack, and I'll take some questions after our amazing guest speaker is finished with her session. For now, no further ado, let's, what's it called? Welcome, Alex. Hi. I'll end my screen share.
Hi, how are you?
Welcome. I'll hand over the mic to you. Thank you for being here. I really appreciate it, and we can't wait to learn from you today.
Of course. Thank you so much. I'm so excited. All right,
Yes.
let's see if we can get this figured out. Let's see. Hi, everybody. I hope everyone's doing really good today. I don't know what time it is, where everyone is. Let me see. Over here, it's still 9 o'clock, so not too shabby.
Where are you located? I'm in Dallas. I'm in Austin.
I'm in Kansas.
Okay, cool.
Yes, it's definitely different. I'm from Florida originally, so it's very different. I'm like, oh, okay. Let's see. Oh, 5 p.m. Nice. 6. Okay, so a little bit late. Okay. Evening time dinner. Oh, geez. All right, let's see.
You can ignore the poll I just sent out. It's just for attendance for the first part of the session.
Gotcha. Okay. What is going on?
Yes.
Okay, I'm going to share my screen real quick. Okay, so can everyone see it okay?
Yeah.
Okay, awesome. All right, perfect. So my name is Alexandra Palacios. I am a very non-traditional student. I started this track in basically 2016, technically 2011, when I first decided going into college that I was gonna become a doctor. And you know, it was a very rocky story from 2016. We're now in 2023, and finally everything that I did is coming to fruition, and I'm gonna finally start medical school in about 2 weeks. So I kind of wanted to show my story to give maybe somebody who is in a different situation, certain circumstances, maybe they've never had somebody in their family who's been a doctor before. You know, this is all new to them, and to give them some hope and some kind of reassurance that it's not an overnight success. It's not a, you know, one-shot thing, but with dedication and hard work and, you know, falling into your strengths, you can definitely do it and accomplish anything. So this is my story. All right, so let's get started. So we're going to take it way back. So when I was about 11, my dad had a stroke, and it was ischemic stroke. It basically started as an embolism, went up to his brain, and it popped, for those who don't know, and then it caused bleeding in the brain. And because of how long it took us, in the middle of the night, it took us a long time for us to even know that it was happening. So we weren't aware of the symptoms or anything, of, you know, the FACE synonym, if you guys know of that, or acronym. And so by the time the ambulance and everything was there, they had taken him to the hospital, and he ended up being okay and everything, but it did paralyze the right side of his entire body. So with that, it definitely caused a lot of struggle financially. And my family worked very hard. They both had both incomes with my parents, and it was a big financial burden. So my mom had to take over. If you know anything about how expensive it is for medical care in the United States, you know, prescription drugs for us were about $1,000, $1,200 a month. And that was back in 2004. So it has just skyrocketed since then. So my mom basically took up 3 jobs. She worked part-time. And when I could, finally at 14, I helped her with finances, and I became a after school assistant teacher. And it was really nice because I was able to kind of step away from being around hospitals and medicine, and being around that scene for so long. And it was a nice change. But even then, I took care of 8-year-olds, and if anybody has kids, they're very rambunctious all over the place, nieces and nephews. So it was a trip. But with that, it kind of gave me perspective and made me realize what I wanted to do. And so I started focusing on medicine. I gained a scholarship. I went to the University of Central Florida in Orlando. And the big transition that I had was, I am the oldest of 3. And so my siblings looked up to me. I also worked full time while I was in school, and high school was something that came very easy to me. So when I transitioned to the university level, I thought, okay, perfect. It's going to be the same thing. And I was clearly very humbled quickly. And within my freshman year, I saw that, or after my second semester, I saw that the workload was a lot different than high school. So I know I do pre-med mentorship now, and a lot of the things that we talk about is trying to figure out, okay, how to approach college, how to tackle the things you're going to do, and understand that there's a mindset shift. Because even if it's something that you do well in, it's something that everybody goes through, and understanding that you're not the only one dealing with it, and to seek help very early was something that took me a long time to understand. So freshman year, thought I was doing great. I took up a job, and I started working really, really hard, just like I did in high school, did 60 hours a week. And my workload was way too much, and I prioritized work over that. And then my sophomore year, I continued to do that rather than step back and ask for help. And I saw that my workload just got worse. I still couldn't accept it. I was still very much, push forward, you got this. My major at the time was biomedical sciences. It later turned into health sciences because I needed to be a little bit realistic, but biomedical, so still medical major. At the time, I didn't know that you could do any major and still go to medical school. But at the time, it was very much, this is what you need to do and everything. So I did biomedical. And my sophomore year, I ended up failing a whole semester. I had 2 family members pass, and it was just all kind of crumbled all at once. And at that point, I was like, okay, now it's way too late. I lost my scholarship for school, and I got to a point where I had to work, and I couldn't step away from my studies and everything. And so it ended up being something that at that point, it was kind of one of my milestones, because it was okay. You're either, at that point, I think I had a 1.8, 1.9. It was very low. And it was either you were going to keep going and turn this whole thing around, or you were going to switch careers right then and there and see what happens. And so after that, I slowly started working on my studies. I kind of dropped down a little bit in how much I worked. I took out loans, and I was very hesitant to do that, but I knew that the alternative, which was me working, wasn't an option. Asking my parents for money wasn't an option. And so I made the decision to start taking out loans at that point, and knowing that the career I was going to go to was something that was going to eventually pay back. Obviously not the reason why you want to do it, but still. Thank you so much. I'm sorry. I'm like trying to get through my story and then chat. So if I don't answer, if I don't see something, I will definitely go through it and then answer your questions. So definitely a lot of burnout very quickly sophomore year. And then throughout, I just kind of started focusing on changing my mindset shift and trying to understand, what do I need from this point on? So I did that throughout the rest of my college career. I think now you're able to, they've cut off how many credit hours you can do in college. And honestly, I think it's really good that they did that, because I had entered with so many college credits. I had about 10. And then I did summer, and by the point where I was, it was very hard for me to change my GPA because of how many credits I was at. And that's something that was hard for other people to understand, because they see a GPA and they're like, okay, well, clearly, there's some sort of capability or maybe some intelligence that's missing. And that's not always the case. And so we went through that. I graduated in 2016 with a 2.7, and I had brought up my GPA up until that point. And admittedly, I knew that it was still a very low GPA. That was something that I was not going to be able to apply to medical school with. And I reached out to a few advisors. They said the same thing, definitely change careers. And it wasn't very helpful. But I knew that I wanted to be a doctor. I knew that I could do it. But it was very hard to face that reality that where I was, the person that I was at the time, was not going to get there. So I ended up switching careers. I went towards pharmacy. I worked in retail pharmacy for about 8 years. I started as a pharmacy tech. I worked at CVS, and they taught you from the very beginning how to, become a technician, how to read medication, how to understand how things worked, how to process things, how to contact providers and work with insurance companies. Because there is a communication style that you have to do when working with different people in healthcare. So that's something I learned very quickly. Dealing with patients, you would see people who would come in and have to have these life-altering medications like insulin, for example, and be expected to pay hundreds of dollars for these medications that could affect their livelihood. And so understanding how to empathize and be on their level, but also give them options, also provide some sort of information. And you could only do that from gaining knowledge, from being knowledgeable about the medications, the alternatives, communicating with your pharmacist, having medication assistance plans and things of that nature that would help these patients and actually give them some sort of but some sort of assistance. During that time, so I started at the end of college, and I had kind of worked through that. And when I graduated, I was personally in an abusive relationship. I didn't know at the time because I was just focusing on school. Once I left that, I was like, you know what? This is my chance to really push myself. And I learned to be on my own. And, I bought my Jeep for the first time. Her name's Sheila. And she's been with me throughout this whole thing. And it was just a big life change that I needed to really face this challenge. And so I did that. I worked in the pharmacy, and I continued on. And in the back of my head, I always had medicine, but I just wasn't at the place where I could see myself applying, spending all this money and getting in. I hadn't really seen anybody else do it. I didn't have a lot of advice on people who were non-traditional, people who were doing it with families, people who were doing it, coming from disadvantaged communities. I didn't see any of that at the time, because Instagram, I think, wasn't really a thing at the time, and social media as well. So not the way it is now. And once there was a point where I think it was about third year in pharmacy, and my pharmacist, I had gotten to where I was really comfortable, and he looked at me and he's like, you you want to do this, for the rest of your life? Is this really what you see yourself doing? And I looked at him, and thankfully we had a really good professional relationship. And I was like, no, I love what you do. I think what you do is incredible, and there's room for pharmacists. And if that's what you want to do, awesome. But just, I wanted to be part of the beginning. I wanted to be part of figuring out treatment plans. I wanted to be part of understanding someone when they walk into a room, making them feel comfortable, and really trying to, get their story and be able to help them and see their progression. That's what I really wanted to do. I didn't want to come at the end and be able to provide them with something and then hope that they maintain their medication and hope that they did everything that we went over. And, I really wanted to be part of the care at the beginning. And so I found a Facebook post on one of my old college groups, and it was a scribe position. And at the time, I had looked at other positions like scribing. And when you're in a position where you work for a living and you can't just stop working to study, you can't make that switch. Scribing at the time didn't have online programs, it didn't have self-paced courses. And so for me to switch, I would have had to give up my job and go down in pay and not be able to support myself. And so it was one of those things that I do recommend if you're in college, if you're looking at positions like CNA, nursing, pharmacy tech, radiologist tech, any sort of tech positions that are a little bit lower. I definitely recommend looking at that while you have supportive loans or anything on the side, because once you graduate, it's really hard to do that and also balance work. So that's my only little tidbit. But so I switched over. Phlebotomies. I learned that years later. I wish I would have learned that sooner. But yeah, great things, but they also cost money. So definitely things to think about if you're looking for certifications for that. But they are a good investment. And so I did pharmacy, and then I found this Facebook post, and they were looking for a medical scribe. It was for private practice. And at the time, I think it was like $12 an hour. It was going to be a very part-time thing. I would be able to get shadowing experience. And I had already, by this point, tried to apply to medical school. I went in blind. I thought, you know what? Let's just see what happens, And for anybody that's done that, please do your due diligence, please do your research. It is very expensive, and it's something that you don't want to just try it just to see. Because the entire cycle is very, very hard. It's a waiting game. And so for you to have to do that more than once, I don't recommend it if you can avoid it. So I found this Facebook post and I applied, and the doctor ended up being a OMT, DO, an osteopathic physician, and she had a private practice, and she focalized on OMT, or osteopathic manipulation treatments. So she did assess patients just like a regular doctor, took in all their information and made treatment plans and all that. But on top of that, she learned an extra skill that osteopathic physicians do, which is OMT or OMM. And this kind of allows you to learn certain techniques that work with the body. Kind of like one of them that people know is lymphatic drainage. It's a very small subset of it, but it is helpful. It is beneficial in the body. And so I saw with that, I was able to see patients who came in who had genetic disorders that had some sort of contribution in neuromuscular skeletal ailment. People, kids who had birth defects, who she could help with osteopathic manipulation. I saw patients who had motor vehicle accidents, who were affected and had acute, back issues, and she was able to help them with manipulation, really get to a better point. Did it fix the issue? No, absolutely not. But it helped them release tension, and it helped lessen inflammation, and it helped really just overall lessen pain. And a lot of times, a lot of these people, that's what they need. They haven't been heard from different physicians, and they've gone through the system, and it's very disheartening to see that and to feel like the case that you're going through or the pain that you're going through doesn't feel real, it isn't validated. So being able to see a physician do that and give them options and show them how important a team was and connect them with other physicians was incredible. And through that, I became a medical assistant. We did things like regenerative injection procedures, which basically, for those of you who don't know, is your own blood. It's concentrated. We draw your blood, which is where the phlebotomy came in. And we concentrate it in a centrifuge. We get the growth factors out of the serum component from the blood. And then she injects it back into the area that needs some sort of tissue growth. And it creates sort of an inflammation cycle in that area. So essentially, if you were to, simplistic terms, if you have a cut on your finger and eventually you'll see it start to heal and it scab, and over time it heals on its own, that's the inflammation process cycle starting on its own. So what we do is just a very concentrated form of that. And it was incredible to see the results and to see patients that maybe needed knee surgery, but it gave them an extension for a few years, or maybe somebody had a tendonitis, which is like inflammation of the tendon, and it helped restore that a little bit. And just a lot of different cases that I was able to see in a year or a few months to a year or 2 years, even seeing that drastic change. So that was really, really incredible to be able to be a part of that. And something that I wanted to incorporate in my practice in the future. Within this role, I was able to learn what a private practice entails. We didn't take insurance. And so I didn't see so much of, I saw the billing, but not as much as insurance companies and hospitals and other practices do. And it was one of those things that made me really question our healthcare system in the United States and understand what kind of things lack, especially in terms of time management and services and finances, things that we could provide a different kind of experience for patients. So definitely something that I looked forward to. With that, she also encouraged me to apply to a master's program. At this point, I had applied to a few master's programs before her, but I knew that if I really wanted to do this and go into medical school, I had to show that I had the capability, I had the intelligence to do well in these rigorous classes. And the only way to do that was either through a post-bac or a special master's program. Two options that we have here. The nice thing about special master's programs is that they are designed to help people who maybe need to improve their GPA, have lower GPAs, maybe they switch careers and they don't have a lot of science classes that they can prove. It's very helpful. The only cons with those, or a few of the cons, is finances. They are expensive. It did bury me a little bit in that. They are hard. They're between 1 and 2 years. They're expected to be a certain difficulty. Some people compare it to the first 2 years of didactics for medical school. So sometimes I've had people go through it just to get a kind of a rundown through medical school to make sure that they can really handle the rigor of that. Some of them also have what's called guaranteed interview admissions. So some states have, certain schools have certain criteria where if you have above a 3.0 and you meet a certain MCAT and you have 2 letters of recommendation and you do well in their programs, for example, you get an automatic interview. So that's definitely something to consider, if you are applying this cycle or next cycle, even if that's in the future, to kind of help that and have some sort of backing. Ended up graduating from Case Western at a 2.7, so I did really well. I was a 3.7. I was very proud of myself. They were very supportive, very collaborative, and I learned a lot about stroke victims, which is what I wanted to learn essentially because of my dad. And I became a pre-med mentor through that, and I was able to help other people coming into the graduate level, and then so on. I've continued to do that through my Instagram. So I had to take the MCAT 3 times. It was brutal every single time. I wish I could say that it wasn't, but it's just one of those things that it is. But at the end of the day, it doesn't define who you are and what you bring to the table. So got through it, and here we are. And now I am settled in. I am in Kansas, and I will be starting medical school in 11 days. So it can happen. So I wanted to go over kind of why I did this, because over the years, it took me 7 gap years to really get through it. Thank you. to really get through it. And I'm not saying that if you have certain circumstances that kind of swayed you from this, that it's going to take you 7 years to accomplish. Absolutely not. I really didn't have a lot of guidance going through it at the very beginning, even the first 2 years. And it wasn't until I had the clinical experience that I started to have confidence in that. And once I got to a place where I was kind of working 2 jobs, where I was comfortable, I had savings, I had things like that, then I went ahead and started looking at options. I tried again, and I got into a really good graduate program. So sometimes it's just not what it needs to be at that time. I did pursue other paths. I did look towards pharmacy at one point or another, just to make sure that this was what I really wanted. You know, sometimes when we do things, we have no idea what it really entails. That's why shadowing is so important. Clinical experience is so important to really understand what that lifestyle is like and to see yourself in it, because sometimes medicine is romanticized and it's not like that. And so you really want to understand what you're going into. If you're going in for the money, you're going to burn out very quickly, because you got to be a certain type of breed for this. So money is not enough. DO versus MD. The first time I applied to MD and DO schools, the second time I applied to DO schools only. And I made that decision because I wanted to really make sure that whatever degree I pursued, because it had me so long and gone to all the list, I really want to make sure I make the best decision for myself. And so I'm Peruvian. We do a lot of homeopathic, naturopathic methods. You know, whenever I got sick, vapor rub was what we use on everything. And so things like that, menthol was the way to go. And so I wanted to be able to incorporate different methods. I didn't want to just do Western medicine. I wanted to Eastern medicine. I wanted to incorporate my culture. I wanted to incorporate, you know, herbals and different types of methods to treat different things, but also use clinical studies to back all those things up. So I felt like the approach to medicine in Western medicine and allopathic medicine is specific, and it's something that just didn't align with me. And I didn't feel as comfortable talking about it versus osteopathic medicine. That is how I approach patients. I see them for the mental, the physical, the spiritual. That is how I want to approach my future patients. So with all of that, I knew that there was best approach for me and the best track for me. And, you know, at this point, if I had the option, I might as well be a little picky, you know, why not? And it was just honestly, the tool of OMT, just being able to see that and seeing how beneficial it is. Now, I will say I've worked with DOs that don't use OMT, that don't use OMM. Manipulation is not part of their practice, and that's okay. They learned it. It was part of their boards and their curriculum. And at some point they had to understand it, but it is not anything they specialize in, and they are excelling. They're doing great. It was great to work with them, but it wasn't what I wanted to do. I saw the benefit of that, and I want to open a practice maybe in a more rural area, and I know how much that would benefit my future patients. So for me, I knew that that was really, really the thing that was going to switch it over. So being that I am someone from a non-traditional perspective and from a lower GPA, I wanted to focus and talk to those people. And this applies to anybody, but more so the people that have certain circumstances that may feel like you are not prepared enough, you are not capable enough to do so. So some tips that I wanted to go over: lean into your strengths, whatever they are. The biggest things that I will say with this cycle was my ability to network. I went to so many webinars. I went to so many seminars, attended. They were free, of course, because money can't, girl does not have money to spend like that. So they were all free. And they were all online. You know, they were great speakers. You know, we're in a day and age where social media is able to connect us on a level that has never happened. I wish this would have been a few years ago, but you're here. And so take advantage of that. And connect with all these organizations that are putting these things together. You know, reach out. If there's somebody who's a speaker, they can probably, if it's a physician, for example, they're probably more likely to have the time to shadow, maybe, for example, or maybe do mentorship. Maybe that's something that they can do and you can connect with them. Or if they can't connect with other people, a lot of the organizations would do kind of big seminars where you can connect with different people. You can see different specialties, email them. Biggest thing, email will take you so far. Learn to put good emails now. You're going to be emailing up the woo-ha forever. So you might as well start now. Learn how to put yourself in a place where people want to talk to you. And it doesn't have to be, anything crazy. You don't have to say I cured cancer and I was part of 8 publications. None of that. You just have to focus on what makes you you and lean into it so hard, because nobody else has your story. Nobody has your perspective. Everybody may be an MA or a tech or whatever, but they didn't see what you saw. They didn't go through your life and then get to that point and have their own understanding of it. You're the only person who can do that. So lean into that. Remember that, use that as your strength. I'm a writer. Writing is what makes me happy. It brings me joy, but it's how I connect with people. And that is how I was able to grow and connect with people through social media. So, and when I applied in my storytelling, in personal statements, in my secondaries, I was really able to highlight who I was as a person and show that. Another tip I want to do is, everybody has blemishes on their application. Nobody's perfect. You might have gotten that C in organic chemistry. You might have had to withdraw from physics class at one time. And at the end of the day, when you apply, when you go into it, you want to remember that it's not going to go away. I'm going to be honest with you. You can't hide from it. Whatever happened in the past is there, but it is part of your story. So you might as well shift your perspective. And when it comes up, be ahead of it. Don't be surprised when somebody asks you, oh, there's a gap here, or maybe your GPA was here, or maybe your MCAT was maybe a little bit lower than you wanted. What happened? What could you have done better? Always be ahead, always acknowledge where you are and your circumstances, if you had any, touch base on that, but always focus on how you could be better, because everybody has something that they went through. And the defining moment wasn't that they went through it. It wasn't that life hit them in the face with some sort of obstacle. It was the fact that they made the conscious decision to continue moving forward and deciding, okay, this is what I want to do. I can either change it or accept it. So having these conversations written down, interview, it's going to come up in interviews, it's going to come up in stories. So you might as well kind of put some sort of spiel together to not be surprised from it and kind of be ahead of it. With GPA, with stats, with applying, if you can focus on your MCAT, if you can take off a few months, if you can lower your study, how much you have to work or extracurriculars to make time for this, do so, because stats are not everything when you apply, but you don't want to just show up with low stats and expect that I'm here and what's up. You have to still show that you're capable and you're competent, and those things unfortunately are shown by your GPA and your MCAT score and your clinical experience and your research experience. So all of those things are going to make a difference. With improvement to GPA, again, there's SMPs that we talked about, there's postbacks, there's DIY postbacks. Look at which one is most helpful for you. They're all very, very different. I know I didn't go into postback too much because I did an SMP, but it is something to consider. If maybe it's a few classes, maybe finances is an issue, you can do that. They're still helpful and they can still show improvement and that you're capable. Like I said, just accepting what happened as part of your story, regardless of what it is, regardless of how bad you think it is, regardless if you think that nobody's going to understand. I've learned through this that there's people out there that have been through similar situations, maybe don't understand the exact circumstance or situation you went through, but they are able to level with you and you are not completely alone in all of this. You're not the only one that failed something or got a C or, didn't do well or bombed that interview or had to apply a second time. You're not the only one. So try to find people like that and find people that can inspire you to do better and, go from there. The biggest thing I will say when I applied is I was very realistic with my application. I knew that there were some schools that were going to see that as a flag, and their computer system was going to drop you out. Every school cycle, application cycle, at least M.D.s, there's like 60% of students that don't get in. So it's not that, oh, you're just not smart enough, you're not good enough, it wasn't enough. There's not enough spots. So you have to focus on being really smart with how you do it, focusing on what you bring to the table, what's unique to you. And then with the screen out process, there's certain schools that have to have a screen out process. Within a certain GPA, they can't accept you. They have to have some sort of kind of weeding out system. So that's what they do. So I'm going to include the website that I used, the Shemessing consulting that they do for pre-meds. They had a blog article and it's really thorough. It's really great. And they show minimums of MCAT and GPA for MD and DOs. And honestly, I used that to really cater to what sort of schools I was going to apply to, where, and make sure that the schools I was applying to, I had some sort of connection, some sort of networking, aligned with their mission, and they weren't going to screen me out. They weren't going to see my application and just toss it, because then you're spending money for what? So definitely take that into account. It does happen, and being smart about it will help you. Don't take no for face value. So there was one school that I got an interview for, and she, excuse me, I had done a program with them. They had like a little summer internship program. I applied to that. I was like, okay, cool. It's 3 webinars. It's 3 different days. I'll learn from this school, maybe get an interview, maybe have some sort of connection. They'll be able to pick me apart from the 1,000 students applying. And when I got to them, they asked for my MCAT. And at that point, I could have, I got a generic email saying, hey, this is your MCAT, da, da, da. It's not really meeting criteria. If it does better, please let us know. I went ahead and emailed them. I explained to them that I could see myself there, that I was, my skill sets, the characteristics I could bring to the table, and my why. And then the fact that I had done their program. And so they knew me by face. I knew some of their faculty. I could connect with some of those people. And having all of that, I was able to say, if you consider, I will retake my MCAT with this cycle, and I will, if you'll allow me to move along with the process and give me an interview, respectfully, of course, then we'll move forward. And that's exactly what they did. I could have taken that as a no, and I ended up getting an interview for them. Later on, I got acceptances to other schools, and so I retracted that. But at the time, I was like, no, there's a chance, I'm going to ask for it. So if there's a chance, that's why there's letters of intent. That's why there's update letters. If you think that, you never know what'll happen, and don't just take, oh, they said this, they emailed me this. If you really want this, go after it, ask, close mouth, don't eat. Remember that, and go after what you want. And then just lastly, just remember that this is your story and that nobody can take this from you. It doesn't matter what happened in the past. It doesn't matter your circumstance. It doesn't matter that you don't know anybody in medicine. Nobody in your family is a doctor. You don't have the finances. You had a family when you were younger. It doesn't matter. If this is truly, truly what you want to do, there's someone out there who has lived or who has had a similar experience who's doing it. So it's not about the circumstance. It's about your decision to move forward. And if you truly want this, you'll make it happen. Is it going to be tomorrow, next week, next month, next year? Probably not, but it'll happen. So, and then finally, I just wanted to go over my stats for my final application cycle to give an idea of what people can expect. I know that when I saw this, as I was going through, being able to see people's experiences and how they wrote down their secondaries and their personal statements, and really having an idea helped me realize that I didn't need to feel so I didn't have to have this perfect application and this perfect setup, or be the best writer in the whole world. I just had to have my own story and show it and work on it and do the best that I could to show up for it. So in my actual application, I did that. Storytelling, networking were huge for me. My personal statement, I rewrote from the first cycle to the second cycle. I reached out to people. I got different feedback from my my graduate mentor. I got it from my doctor that I worked for. I got it from people that knew me that weren't in medicine, so they could see, you know, more simplistic. You know, I wanted to give to somebody and they could tell me, oh, okay, I can tell that you're A, B, and C. Because if they can see that, then admissions can see that, and that'll just help you. So don't underestimate your friends that aren't in medicine. You don't have to be a genius to be able to read a personal statement. You have to, if you can invoke emotion, you can connect with that reader. That's going to be better than you showing how great your research was in 1 year, you know? So just think about that, connect with people, focus on that versus the latter. Attended seminars, I made connections with people. So I had connections with all the people I interviewed. I had at least some sort of connection. I was either in a program that they did, I was either in a webinar, I emailed them a few times, had a thread going on. So I was in contact with people at the schools that I applied to for the most part and got accepted to. The other thing I will say is that don't count opportunities. One of the people that I think was a big help for one of my interviews was my best friend who's an ER resident now. She went to ACOM in Alabama and her mentor was at her wedding. And my husband sat next to him at her wedding and they chatted about whiskey. I don't even know. I don't know anything about whiskey. So my whiskey people, that's not me. But they chatted and he told her, oh yeah, you know, I met her. How'd you meet the bride? Da, da, da. ACOM. Oh, you're okay. Yep. Switch seats with me right now. What did we do? We swapped. We talked for 30 minutes. I was still in contact throughout. After that, that was December of the cycle, and I was still in contact with him, and I got my acceptance in the spring. So I will say that you don't know what'll happen, who you'll meet. So don't discount anybody, because had I been like, oh yeah, you're an old professor of hers, that would have been a connection that I missed. So don't discount that. My MCAT was a 498. Yes, it was just below average. I did have an upward trend with that. So I will say that my lower stats were offset by my clinical experience, which I'll show you in a minute. If you can see, my undergrad was 279, my grad was a 37, a whole 360. I included CEs. I did a lot of CEs throughout my pharmacy technician. So I included those because I learned a lot of information. I felt like you have to do CEs as a physician anyway, so might as well throw that in there. As experiences, I talked about being a content creator. I am on social media. I'm a mentor on there. And I also talk about lifestyle, beauty, things like that. I was a wellness coach at one point, COVID immunizer. I was part of the immunizations. Like we had a rollout for CBS in my community. I was part of that, as well as PCR testing and teaching people how to do that and really helping patients in that. I got research, ironically, in the position that I was when I became a medical assistant. She was trying to have figure out how the efficacy of her injections were on patients and really get it into a form that could be shown as research. And I jumped on that opportunity. I said, do you need help? I will help you with that. Absolutely. And that became something that I could use as research in a clinical aspect. I was a crisis counselor. I needed more volunteer experience. That is a great way to do online volunteering. I had 8 years in the pharmacy, 4 years as an MA essentially. And I needed leadership roles. I needed something that was recent. And so I ended up connecting with somebody from my graduate program. They were the president of this organization. I emailed them, I applied for the position. It was a new position. And I ended up creating an online auction and then establishing a scholarship. And when I say this, to some people that I've mentioned, they're kind of like, you created a scholarship, you have an annual scholarship, that's crazy. It is not as hard as you think. I'm going to be really honest with you. And to be frank, you don't go into these positions knowing these things. I didn't go into it knowing what a fundraising committee leader was. I didn't know going into it, I'm going to create a scholarship. A lot of these things comes from communication, talking with your team, and just figuring it out along the way. And being okay with stumbling along and just knowing that I want to get this done and I will talk to you and learn and figure out what I have to do to get there. So if you want to create a scholarship, I've seen people do it online on their own with no money, and then they've gained traction and it just kind of happens. So just whatever it is that you set your mind to, don't discount yourself. I did articles online. I was a guest, a ghostwriter for some articles online, more so Nothing research-based, nothing clinical. They were more personal inspiration type pieces. And then my clinical hours, my volunteer hours were a lot higher than other students. I was in the 15,000 range, volunteer and shadowing almost 3,000, and then really strong letters and committee letters. So I will say that with lower stats, you do have to offset it. You do have to show you have other capabilities, and long-term, having letter writers from people that can really vouch for you and show you're capable, all of that is going to be helpful. So if the GPA is something that you can work on, definitely focus on that. If you're in high school, if you're in college, don't discount that. Do your best to finish as strong as possible. If you're in grad program, keep going. If you're going to do a grad program, make sure that you are going to go into it knowing that this is your second chance and you're going to do the best that you can. And that's about it. So if anybody has questions, I'm going to go through the chat and see if I can answer any questions that you guys had. Let's see. Okay, so what does it mean to scribe? I was a medical scribe, so essentially you go in with a physician or multiple physicians, depending on the level. If you're in a hospital, you'll be kind of passed around. And you basically are just putting in all the patient information. So you use something what's called a SOAP. You start with an HPI, which is their health information, their story, essentially why they're there, their chief complaint, the observations of the doctor. They'll do the physical exam, and then labs, anything like that that's included, images, you'll include all that. And then finally you do, for DOs, they do, at least for us, I was used to having a section for OMT. So we would do somatic dysfunctions and then the actual treatment to help that. And then finally you do assessment and treatment. So what the physician thinks is going on, diagnosis codes, ICD codes, and then how they think that they can help and what treatment plans they want to offer to that patient. And all of that is something that you're communicating with them. You're going over it and having that ready for them so that they can focus on the patient. How would you get shadowing opportunity? So the shadowing opportunity really depends on different things. As of this point, I would use social media. I didn't have social media when I started, so I had to do cold calling. I set that email up and made sure to send it to different physicians. I went to hospitals. I looked at the directory and I emailed just thousands of different physicians. And as soon as I had a yes, that's where I went. A lot of times with volunteering, I noticed it was a little bit easier to do. A lot of hospital programs will have volunteer experience, or excuse me, programs. And so going into that, once you're a volunteer, it's much easier to have connections with these physicians and different people in the healthcare system and ask them, hey, can I shadow you? Can I shadow you specifically? So definitely trying to get your foot in the door. So volunteering, pre-med organizations are a great way to do so. They have opportunities to share all the time. Social media, I've met physicians that I've shadowed through social media. You'd be surprised. And cold calling and things like that, just trying to go through and making sure that you're just persistent. And then once you are in a position, from there, it's much easier to connect and branch out. Just organize it. Thank you, Mon. That's very nice. Appreciate it. Yeah, it's a lot of resilience for sure. Let's see. Yes, I will definitely take it with me. This has all been part of my journey and it'll only make me a better physician. I know that. I appreciate it. As is decreasing opportunity match as an MD. No, not at all. A master's program does the opposite. It will show that you can actually handle these courses because they're not courses that it depends on the program, but the SMPs, for example, in my course that I did, it was at Case Western. It's a top 25 medical school. They're very research-based in Ohio. And my courses that I took were things like clinical reasoning and translational physiology. It was very physiology based. So they broke it down in blocks the way the first years in medical school are. I did a cardio block. I had an exam at the end. I did respiratory. I did all the systems. I went through it. And you did that for the first year. And then after the first year, you did a comprehensive exam on all the blocks, on all the organ systems that you did. And then after that, you started to focus on more elective things. So I did sleep disorder physiology, and I focused on cases that had to do with sleep disorder and how that functions with the body. I did clinical reasoning, so it was a lot of different diseases and being able to approach them. A lot the kind of the way that they do board exam questions. You'd get a vignette, which is basically a story of a patient. You know, Sarah's coming in with, she's 16 years old, she's coming with respiratory issues, da da da. These are her labs, da da da. What would you do? What is going on? The first question is, what disease does she have? The second question is, what would you do? The third question is, you know, how would you approach this? Her labs are this. What would you do? And so they were very, very clinical based. And I felt very prepared. And a lot of the students that I've mentored, as well as people ahead of me and coming along with me in the cycle that have done master's programs, have felt very prepared because it's not anything new to them. They've gone through these organ systems, they've gone through this type of learning methods. And so I would say it's more helpful than not. And yeah, I hope that answers your question. What's important thing in student CV to get a scholarship?
I just wanted to let you know you also have people have raised their hand to ask questions. So if you want to get to those whenever you have a second, that would be awesome.
Oh, sorry. Okay, let me do that.
No.
Thank you for letting me know. I don't even see you. Okay, let me do that, and then we'll swap back so I can do that. All right. Aya, is it working? Unmute. Okay, go ahead. Can you hear me?
I don't think your mic is working. You want to send your question in the chat and then we can move on to the next person?
Okay, I'm gonna go to the next person. Malak, am I saying that right?
Yes, hello. Can you hear me?
Yes. Hi.
Okay, hi. At first, you are such an inspiration. Thank you for telling your story. It's emotional, I swear. Second, can you talk briefly about the part of your journey with social media and storytelling besides the scientific stuff?
Okay. I just want to make sure I heard you clearly. So you want me to talk about my journey through social media, or?
Yeah.
So with social media, it ended up being in 2019, I applied for the first cycle, and I was, like I said, very humbled, and it hit me like a ton of bricks. And I felt very alone in the process. A lot of my friends had graduated and they were on either in medical school or they were in totally different career paths. And a lot of the people that were around me had no idea what I was going through. And it was very, very isolating. And so I turned to social media at the time to kind of make it a kind of a diary to really show like my process and maybe be able to connect with people that were in similar boats, who could understand what it was like to go through the journey. And I continued to do that over the years. And then I got to a point where I felt like I could start sharing my process, and people started asking me questions. Oh, how did you do this? Or how did you do this? How did you overcome blah, blah, blah? And I started to realize that I could actually share information and try to mentor people, because I had been doing this for years at that point. And, you know, after a few years, you start to learn a thing or two. And I figured, you know what, instead of having people look for them, maybe I could be a source of information. And if I can't find it, or I don't know that information, I will tell you, hey, maybe look for this, and it gives them something to look for. Now at this point, it's more of a mentorship thing. And I have gotten a lot of opportunities through, which I'm super thankful. I've been able to work with companies that align with what I do, and also help pre-medical students and medical students, and actually like offer them to students. And it's just been amazing. So that's kind of where that went.
Okay, great. I will first your username after ending the session.
I'm sorry?
The first thing I will do after ending the session is searching for your username.
Oh, okay. I will share it, but it's Dr. P to B.
Okay.
He's still Dr. P to B. So it's full Dr. P as in Peter, 2 TOBE.
We'll send it on Slack afterwards too, so you all have access to contact her.
Oh, perfect. Thank you. Okay. Let me go out to the next person. Basma?
Yes, hi Alex.
Hi.
I was curious about what you do think about gap year high schools, if I need to prepare more, achieve what I want.
I'm sorry, say that again?
I was curious about what do you think about gap year after high school, if I need to prepare more.
So personally, I didn't take a gap year until after college. It's usually the norm to do it after college, but to be really honest with you, looking back at my entire journey, I've had 7 gap years. I don't regret any single gap year because every single gap year brought me to where I was. It brought me to my support system. I met my husband. I would have been in a totally different place, probably miserable. And I'm just so thankful. So every single one was either a blessing or a lesson, one way or another. So if you feel like you need to take 1 year off to really put yourself together, maybe your finances, maybe set up some whatever circumstance you're dealing with, I think it's a great idea. And I think that at the end of the day, you have to do what's best for you. So if this is the very best decision, shut everybody out, all the other opinions that you have, and do what is best for you. Because at the end of the day, nobody's paying your bills, nobody's living your life, so they're not part of the decision. It's your decision. So I think yes, out of my recommendation, I would say yes.
Thank you.
You're welcome. Also for that, use that time to prepare for college, maybe get scholarships, maybe try to be in a better place. I would definitely take advantage of that. Or if you need a mental break, just do that. All right, let's see. Abdulrahman, did I say that right?
Yes, yeah. You can call me Maddie for short.
Hi. Oh, okay.
Hi.
Hi, Maddie.
So I really want to thank you. This was so inspiring story that you worked on yourself like for like 12 years to join medical school or something.
Mm-hmm. Yep.
I really have a
I have another
kinda
decade to
similar
go.
story. I really have kind of similar story because here in Egypt, the system is different. We don't use GPAs to join the university. We use the total marks of the general secondary school certificate. So I got total marks that cannot match the medical school. So I studied veterinary medicine for a while. I studied like for a semester there. And then I had a request to remark my papers, my exam. So I got 2 extra marks in the certificate. That could match me to study pharmacy. But I really wanted to study medicine. It's hard to explain it, the Egyptian system. But studying medicine was my dream. I really felt like I'm far behind when I lost my dream after secondary school, or you can say the college in your system.
Mm-hmm.
But after this, there was like, because of the COVID-19 circumstances, the medical schools opened vacancies for students who study pharmacy that got a cumulative GPA of 3.3. And I worked hard for like 2 years, I mean, like 4 semesters to achieve the 3.3 GPA, and I got 3.6. And finally, I've joined medical school. Now I'm in my second year. I'm second level.
I love that.
Medical school. That was so hard, but at last, yes, this is your story. This don't discount opportunities. I really appreciate what you said, because people get down when they just lose once. and stay at the bottom. I'm here to say, no, you can try again. There is always second chances, and you can find your dream if you are really serious at looking for it. That's what I wanted to say, and thank you.
I love that. Thank you for sharing that so much. And that's awesome that you got in and you're able to get on your journey. So best of luck to you. Thank you.
Thank you so much, Alex. I know you want to be respectful of your time. So everyone else who has a question, we're gonna link Alex's Instagram onto our Slack today. So feel free to reach out to her if you're okay with that, correct? If they reach out to you, if they have any further questions. Sounds
Yes,
good.
definitely.
All right.
Oh, I just want to say one thing. I will put on my story today. I'll be on a different one, but any questions that you have, I will have a little Q&A. Drop it in there so that I can see it, because sometimes the messages, I don't see them. That way I can answer them. And it's been such a pleasure to be here. Thank you all so much for listening and being here. Thank you.
We have a little tradition where we give a round of applause to our amazing guest speaker. So if everyone can go to the reactions and click the applause sign, we would really appreciate that. So we can really, truly appreciate Alex today. We really appreciate you joining, and we'll definitely send out your Instagram. So if anyone has questions, she'll have a poll up today on her Instagram where you can ask those questions and she will respond to you. So thank you so much for offering that service to us. We really appreciate it. And thank you for speaking today.
Thank you.
Thank you. All right. Everyone, thank you so much for attending our second international camp today. We really appreciate seeing everyone here today. What's it called? Feel free to go. The session has officially ended. We'll send some reminders to the Slack channel in a little bit. But again, please stay for any questions if you have any, and we hope to see you on Friday. Thank you so much for joining. And yes, the presentation link will be sent on Slack like right now. I will send it out right now. And there are no assignments, the homework will be sent at the end of the week.
We will stick around if you have questions about the program. So if your hand is raised right now, then we will assume that you have a question about the program and we'll answer it. Otherwise, we're going to stop the live stream and